Institute in Nairobi, and so I just want to thank all my friends and colleagues in Nairobi for inviting me. The reason why I'm talking about membranous nephropathy is I have a clinical interest in this because over the last 2 years the NHS in England have been, last year the NHS in England have been funding the use of Rituximab in 180 patients with membranous nephropathy who meet certain criteria. And I'm the clinical lead for that. So I just developed a sort of a kind of clinical interest in the disease. So let me just start quickly with a case. So this is a kind of 53-year-old lady who's got very bad nephrotic syndrome, presented to the general medics. She had an EGFR of 46, around 10 grams of proteinuria, and a very low serum albumin. And she had a very high phospholipase A2 receptor antibody level of around 330, so the normal range is 14. And I just want you to ponder two questions, which I'll come back to on my last slide, which will be, would you do a renal biopsy in somebody like this? And secondly, as you all know, people with membranous, you decide, whether you wait to watch or whether you should immunosuppress immediately. So my second question would be, would you wait and watch with this patient, or would you immunosuppress immediately? So just kind of keep that in the back of your mind. As it happened, we did do a biopsy, and that showed the sort of characteristic appearances of a thickened basement membrane with spikes on the silver stain. And she, because she had a lot of ascites, the medics that referred her also did a CT scan of her abdomen. And I don't know if you can see here, but there's a kind of lucent area in her renal vein, so she had renal vein thrombosis as well. Okay, so I'm going to talk about three very quick things, really. What's the role of the antiphospholipase A2 receptor antibody in the management of this disease as we currently stand? What are the outcomes in membranous nephropathy? And very quickly, what are the key clinical trials in terms of immunosuppression? Okay, so there's very little data about PLA2 antibodies in Africa, and the session that I'm replacing was actually the first, as far as I'm aware, data to come out of Africa looking at the prevalence of the PLA2 antibody in a South African population. So I would encourage you all to read the abstract because it will provide you some more relevant data, because all the data about PLA2 is really from Europe and the States. So you all know that kind of membranous, idiopathic membranous is this sort of immune complex disease where you get immune complex formation within the glomeruli that leads to activation of complement and then effectively podocyte injury, which will then kind of lead to proteinuria and progressive kidney disease. And there have been a number of different antibodies kind of identified. So the anti-endopeptase antibody was identified in a child. So this was a case, in a newborn infant. So this was a case of transplacental transfer. Then a couple of years later, this is about 2008, the kind of first reports came out of the phospholipase A2 receptor antibody, which is what I will talk about predominantly. And then more recently, there's been interest in thrombospondin type 1 domain containing 7A, which is another podocyte antigen, which has said to have some association with cancer and may affect, depending on which series you look at, 5 to 10% of patients with membranous. Although in our own experience, we probably found it to be about 1 or 2%. So the data has been remarkably consistent over the last 7 or 8 years, or 10 years, should I say, which is about 70 to 80% of patients with idiopathic membranous will have PLA2 phospholipase A2 receptor antibodies. Okay, it's also present in secondary membranous as well, but at a lower prevalence. And if you stain for the receptor, so if you do immunofluorescence on the biopsy and look for the receptor, you can distinguish primary from secondary membranous. Okay. Its use is that the thing about it is if you do a meta-analysis, what you can show is that this is an incredibly specific test. Okay, so if you have the antibody, you basically have membranous nephropathy, and that's an absolute given. So if you're antibody positive, then because you've got the disease, it really brings into question whether anybody. Whether you should be biopsying these people or not, because this is a pretty cheap test. In our lab, this would cost £25, English pounds to do. A biopsy, I guess, would be somewhere between £500 and £1,000. So if you're in a low income or low resource setting, actually I would encourage you all to think about, and membranous nephropathy is a big problem in your area, then actually doing this test would be a good test to do. So it's got diagnostic uses, it's got prognostic uses. So if you treat with, in these cases, membranous, this is data from the Mayo Clinic, this is data from Italy. If you become antibody negative at the end of treatment, you do better. Okay, so you can use it as a guide to therapy. So if you get them negative, they're going to do better. And similarly, if you've got very high levels of antibody, you do worse. So you're much less likely to go into spontaneous remission if you have high levels of antibody compared to low levels of antibody. Okay, so this is Dutch data. And what seems to be the case is that the antibody is, if you like, more sensitive than proteinuria in the sense that if you're going into remission, the antibody levels fall first in red, if you like, before the proteinuria falls. In a sense, you get immunological remission before you get clinical remission. And similarly, if you get recurrence, the antibody levels rises before your disease comes back. And I'm not going to talk about this because I don't think, well, I'll briefly mention this. So if you look at the antibody in a bit more detail, so if you try and identify different epitopes within that the antibody is targeting, you can show this quite interesting phenomenon of epitope spreading, so that if you have more epitopes that are targeted by the antibody, then your prognosis is worse. So so if you look at the epitope spreaders versus non-spreaders, so these are people with high PLA2 antibody levels. If you only have one epitope, then your prognosis is pretty good. If you have 3 epitopes that are targeted by the antibody, much fewer patients go into remission. So you can imagine a situation where if these antibodies against these specific epitopes become commercially available, then you might be able to kind of refine your approach to treating patients even further. So basically, the kind of antibody is useful, I think, in 3 ways. It helps you it makes your diagnosis. It's very useful in terms of prognosis and guiding therapy, when to start, when to stop treatment. And although it doesn't really tell you about the etiology and you can't rely on excluding secondary causes of membranous with it, you're much more likely to have primary idiopathic membranous if you're PLA2 antibody positive. So what are the outcomes? So this is data from Spain. So in Spain, they have this registry, the GLOSEN registry, which is quite a good sort of glomerular nephritis registry. And you can see that people actually, spontaneous remission is pretty common in this disease. So about 50% of patients will have undergone spontaneous remission after 10 years. And even if you start off with very bad kidney function, so even if this is again from that registry, so even if you start off with a creatinine of around 2 milligrams per deciliter, you can still go into remission without any immunosuppression. And as you all know, ACEs and ARBs, again from that registry, are associated with better outcomes. And if you look at this is single-center data from a Dutch group who took a kind of very conservative approach, if you like, to immunosuppression. So people only got immunosuppression with cytotoxics if you had a high serum creatinine of over 135 micromoles per liter or severe nephrotic syndrome. And in that kind of approach, over around a 10-year period, you can see that the kind of dialysis-free survival was pretty good, it's sort of 86%. Okay, so although there's a lot of interest in immunosuppression, actually a conservative approach does do pretty well for a lot of patients. So who should we immunosuppress and how and why? So this is purely my personal opinion, and I'll just tell you what I think. So in terms of when to start immunosuppression, I would do it for patients who have got non-resolving, severe disabling nephrotic syndrome. I'd do it with people who've got high levels of PLA2 receptor antibodies or people whose levels are rising. In other words, they're not going into spontaneous remission, and people who've got declining kidney function for no other obvious cause. So what does the data show? So if you look at placebo control studies, so if you look at cytotoxics, cytotoxic therapy is pretty effective, really. So this is old data from Italy, Milan, isn't it, in the 1980s now. So that's using chlorambucil. more recent data from Professor Jha in India using cyclophosphamide, but essentially you're looking at 80 to 90% sort of being free of survival at around 10, free of survival from dialysis at around 10 years. Okay? And the real strength of this data is that you've got sort of such long follow-up, although the numbers are small. Cyclosporin, or CNIs. So CNIs kind of do reduce proteinuria in any kind of renal disease, really. And this is data from Toronto. So if you do a trial of cyclosporin, it's very effective at reducing proteinuria. But then when you stop the cyclosporin, as we kind of all experience clinically, you get quite high relapse rates. You can see the remission rates start to fall once you stop the drug. And then finally, Rituximab, when you compare Rituximab against placebo, so this is a GEMRITUX study, which is a French study that treated people with ACE inhibitors for 3 to 6 months, and then they got into the study with ongoing nephrotic syndrome. Rituximab is very effective in purple at depleting antibody, and at 2 years, you've got about 65% who've got a complete or partial remission. Complete remission rate at 2 years was about 35%. Okay? So Rituximab, CNIs, and cyclophosphamide are more effective than placebo. So how do they compare to each other? So this is an important study, I think, partly because I'm from the UK, and it's, I think, changed practice or influenced practice. So this is the UK Membranous Nephropathy study, and this took a particular cohort of patients who had significant progressive kidney disease. So you waited for 6 months to see if they went into spontaneous remission, and if they didn't, you then waited for another period of time and watched their GFR decline, and then you got randomized to either cytotoxics, cyclosporin, or nothing. And I think the take-home message is that people on cyclosporin do very badly. So there's no real role for CNIs with that kind of patient. And that although people on cytotoxics do better, you can still see in this kind of aggressive group, it's not really a cure. It's a kind of, you still get progressive disease. That may be because therapy was started too late. And this was in a kind of pre-phospholipase A2 receptor era. And then, again, data from India kind of showing similar kind of stuff, really, which compared tacrolimus for about 18 months versus cyclophosphamide for about 6 months. And you can see that the remission rate was much lower in the CNI group than the cytotoxic group. And then finally, the mental study, which you'll have all, I suspect many of you will have heard of. So this was published, presented at the ASN last year, and looked at comparing rituximab to cyclosporin, and you see much worse outcomes in terms of complete and partial remissions with cyclosporin than with rituximab. I think it's a kind of, I suspect it's not the kind of study that would have maybe taken off in the UK, because the creatinine clearance to get into that study had to be more than 40, and I think many of us would feel uncomfortable about giving CNIs to people with a creatinine clearance of 45 or 50. But anyway, I think what it really tells you is there's no role of cyclosporin, and rituximab, again, has a disease-modifying effect. What about, really what you want to know is rituximab any better than cyclophosphamide? And we've just got no RCT data at the moment to show whether it is or isn't. There is European data from 2 centres to suggest that cyclophosphamide is perhaps associated with more adverse events without any difference in efficacy. But you've got to be really careful about interpreting this kind of data from observational data, because you don't really get that systematic collection of adverse events that you would do in a randomized controlled trial. So what does it all mean? Well, to me, it means the following. In terms of kind of management, I think, conservative therapy isn't really conservative. It's giving ACE inhibitors. It's kind of monitoring people very closely, so that will suffice in a lot of cases. I still think the evidence base is probably best for those with severe progressive diseases, for those who have cytotoxics. Rituximab, it seems to me, is a reasonable alternative if you can't give them cytotoxics. There's some contraindication to cytotoxics. But I would be aware that the outcome data in terms of follow-up is, I think, stronger for cytotoxics. And obviously, rituximab is expensive, even with a generic biosimilar rituximab. I think really the only type of patient I would give a CNI to is somebody who's really got very mild disease, in other words, effectively normal kidney function and very minimally disabled by their proteinuria. And I think the key thing for perhaps people who aren't doing this is to try and set up the phospholipase A2 receptor antibody test in your labs, because outside South Africa I've not seen any other data, and I think that will really help in terms of starting, stopping and switching therapy. This is the KDIGO kind of approach from the Controversies Conference that was published early in the year. And what they say is if you've got nephrotic syndrome and you're PLA2 positive, you don't need to do a biopsy, you can monitor. If you're high risk, so if you've got very heavy proteinuria, you've got high PLA2 levels, declining GFR, high serum creatinine, then you become high risk and you do get a biopsy. And obviously if you're PLA2 negative, all those people end up on a biopsy. And in terms of starting immunosuppression, that's all based on these risk factors, which is basically GFR, proteinuria, and PLA2 levels. So going back to the patient I presented, this will be my last slide. So you just remember she was a lady, 53-year-old lady with an EGFR of 46 who presented with nephrotic syndrome, very high PLA2 levels, so 20 times the upper limit of normal, very heavy proteinuria of 10 grams, and renal vein thrombosis. So would you need to do a renal biopsy? Well, you certainly didn't need to. This was a really high-risk renal biopsy because when she got to us, she was on warfarin. So in retrospect, we certainly didn't need to do a renal biopsy to make a diagnosis, and it made no difference to her management at all, although you can argue that in other cases a biopsy would be useful. And should you immunosuppress or wait and watch for 3 to 6 months? I think the answer to that is you should definitely immunosuppress her straight away for 3 reasons. She's got 3 very bad prognostic signs. One is she's got very high PLA2 antibody levels. She's got very heavy proteinuria, 10 grams. KDIGO said anything above 8 grams. And 3, she's already had a life-threatening complication of her nephrotic syndrome, which is her venous thrombosis. And that's my last slide, so I'll finish there. Thank you very much.